introduction. And of course, we're going to be aiming to submit a lot more papers into CVIR Onco. So I have been asked, I'm going to carry on in English as long as the chairman allow. So I have been asked to discuss the locoregional treatments, latest update in terms of clinical trials and how they may relate, compete, or complement surgical options. So a little bit of background first, and this is a very rapidly evolving landscape, especially in the setting of liver colorectal metastasis. I'm going to highlight that most of those cases are often inoperable at the time of presentation, with a recurrence rate of up to 70 to 80% out to 5 years. So most of patients with colorectal cancer may suffer or may present with some liver metastasis in the future. So some very important concepts here, because colorectal metastasis has always been the primer in the oligometastatic spectrum, and now we've got some new also terminology that we need to be aware of. So sometimes they are synchronous, sometimes they are metachronous, and depending on whether they have some treatment, we may also have what we call the oligoprogression or the oligorecurrence, and we are often being asked to do repeated tissue biopsies for repeated molecular profiling of those patients before locoregional treatment. And I'm just highlighting this because this is very gaining a lot of traction in the oncology community. Now, as we move on, ESMO, the European Society of Medical Oncology, this is the toolbox well published in the past, but basically there are two main options that are the sort of the groundbreaking treatments. We've got microwave ablation, which is a local treatment. You can imagine this like surgery. We ablate and we destroy a tumor locally. And we've got a regional treatment, which is an embolization therapy, and this is the Y90, the radioembolization that I'm going to be presenting later on. So we've got local ablation and regional embolization, and both of those treatments can have a significant ablative effect, competing to surgical options. What is the concept? As very nicely also explained by Professor Philippiadis in the past, we are looking for what we call an A0 ablation. Exactly like surgery, we've got resections with clear margins, 5 to 10 millimeters wide. We are looking to achieve exactly the same outcome with ablation. So we need to ablate the tumor itself, the metastasis itself, plus a 5 to 10 millimeter margin around it. And I'm going to once again highlight that radiofrequency is most likely a technology of the past. We are mostly applying microwave ablation nowadays because microwave is producing larger ablation volumes quicker and with the same rate of complications and lower rates of recurrences. Now, this is an example here. Left-hand side, you can see a couple of colorectal mets. Right-hand side, you can see the original ablation results, and you can imagine here that the ablation area, the ablation volume supersedes the treatment, the lesion itself, by several millimeters in all different directions. Now, what's the background here? The background to compare with is this is the natural history of a surgical resection for oligometastatic colorectal liver disease, and this is a large series from Memorial Sloan Kettering Hospital, published more than a decade ago, 600 patients, so expected long-term survival 25% out to 10 years' time. So keep this in mind, 25% at 10 years' time. Now let's see how the most important studies of locoregional treatments compare to that. Most important one, the clock one, the very first one, where patients, small pilot study, but still very important, 60 patients in each arm, 60 versus 59, randomized between either systemic chemotherapy plus radiofrequency ablation or systemic chemotherapy alone. So this was the very first landmark study in the field with the usual endpoints of PFS and overall survival. Let's have a look. Follow-up more than 9.7 years on median, and you can see that out to 10 years time, progression-free survival significantly improved in the case of ablation combined with chemotherapy versus chemotherapy alone, hazard ratio 0.57, so significant benefit of 6.9 months on the median PFS. When you have a look on the overall survival, very identical finding, hazard ratio ratio of 0.58. And I will highlight here that at 10 years follow-up, the expected actuarial survival was around 30% in the active treatment arm, so pretty much identical to the one expected, if you remember previously, from the surgical resection. So several years now, from a randomized study, we would expect sort of competing outcomes, combining ablation with chemotherapy versus resection following chemotherapy. Now here comes the collision study, and I'm going to spend a few minutes here discussing the study, which is sort of turning the whole field on its head. Collision study was a multi-center Dutch Belgian randomized control trial, published beginning early 2025 at the beginning of this year. And basically patients with resectable, potentially resectable, and potentially ablatable oligometastatic colorectal liver disease were randomized between either ablation with a microwave device, either microwave ablation versus the standard, the gold standard of surgical resection. Here on the left-hand side, you can see the inclusion criteria. The target was 600 patients, very high-quality study, but the main inclusion criteria was for the low-risk disease burden, 3 lesions up to 3 centimeters. If there were more lesions, then they had to be assessed intraoperatively with intraoperative ultrasound imaging. So by design, there was a multidisciplinary expert consensus panel, and you can see there were 32 surgeons, I beg your pardon, and 31 interventional radiologists, so massive team of doctors and researchers evaluating each patient. And this is an example of the low-risk arm, no more than 3 lesions, how they would be randomized between ablation or resection. The design of the study, interestingly, was a non-inferiority design. So basically, we had to prove whether ablation was non-inferior to surgical resection in terms of long-term overall survival. Hence the 600 patient sample study. And of course, for non-inferiority study, we've got all those stopping rules for futility, either in terms of safety or in terms of benefit. And there was a pre-planned interim analysis when the study had recruited half of the sample size, around 300 patients. And again, stopping rules on both ways, safety or effectiveness. Now, the study was published January 2025, as I said, and actually the study was terminated earlier after the first interim analysis when the first 300 patients were randomized. So the study did not complete its expected sort of plan. Now, why was that? This is the control diagram. It was exactly because the study showed futility for the effectiveness benefit. I'm going to show you a little bit of the sample size first. You can see typical inclusion criteria. Most of the resections in the low disease group were done with a laparoscopic robot, so very high quality surgical practice, and most of the ablations were done, of course, percutaneously in the radiological arm, and around 50% were synchronous and around 50% were metaconus colorectal liver metastasis, so very, very typical case mix of lesions as expected. Now, here are the results. As I said, the study was stopped prematurely. Why was it stopped? Because basically it showed non-inferiority early on. So the hazard ratio was 1.05, no significant difference in terms of overall survival, with a conditional probability to eventually prove the non-inferiority exceeding 90%, and that was the stopping rule. And you can see that the median follow-up in this case was around 4-point-something years. Actuarial survival more than around plus or minus 50% in both the surgical and the ablation arms. So the study showed non-inferiority of percutaneous microwave ablation versus surgical resection for the unresectable oligometastatic colorectal liver cancer. Here are the individual components, which are even further interestingly important, because, for example, on the top bottom right, you can see the local disease control, and there were actually significantly more local recurrences in the surgical resection arm and not in the ablation arm, which is completely opposite to what has been published in the literature for radiofrequency ablation. All the other survival and PFS components are identical between the two treatments. Another point is that percutaneous ablation showed also a superior safety. Again, we are not really surprised here. Adverse events more than half in the case of percutaneous ablation. Deaths, there were 0 deaths in the percutaneous ablation versus 3 deaths in the surgical resection. So basically, I think this is a massive study that actually highlights the fact that we need to be ablating oligometastatic colorectal liver disease instead of resecting it. Of course, there is always a lot of room in case that we need to apply hybrid treatments. For example, there might be one large metastasis that needs to be surgically resected and a few smaller ones that may be ablated in the operating theater. Now, exactly because of this booming ablation technology, there are further improvements and refinements in achieving and confirming the expected ablation result. For example, we've got AI applications. I think Professor Kourokivis later on will discuss further about that, where computers can actually confirm that you've got enough margin ablated around the target tumor to actually eliminate the risk of recurrence. There is also a small randomized study published, the COVER randomized study, that actually showed, I'm highlighting here, that actually showed that the application of this AI confirmatory software can result in higher margin, healthy margin ablation volumes, and hence expected lower rates of recurrence. So this is where the future is going. Now, let's move on to the final part here in terms of the radioembolization. Unfortunately, not all of those colorectal metastases are small enough to be resected or ablated. We often come across liver-dominant disease in the order of colorectal metastasis of several centimeters, 5, 6, 8, 10, 12 centimeters large ones. A lot of patients are unresectable. And here comes the Y90. So basically, Y90 are microparticles with a radioisotope, the yttrium-90. And you can do selective internal radiation therapy by delivering that transarterial to the segments of the liver being affected by the disease. A little bit of early on evidence. Those were the first registration studies with the Sirtex product a few years ago. And on this meta-analysis, more than 1,000 patients. On the right-hand side, you can see that on the, within the liver, the PFS was significantly improved with the application of the Y90 radioembolization. Of course, there was no difference on the systemic PFS. The treatment is just a local liver-only treatment. So for the disease that is confined in the liver and the liver-dominant disease, and those patients often suffer and often die from the liver-dominant disease, Y90 has a well-proven benefit in terms of liver PFS. Now, how are we practicing Y90 today? Because those were outdated data 10 years ago. I'll give you here an example. 74-year-old patient, 8-centimeter large colorectal metastasis, segments 7 and 8 on the right-hand side. We can do what we call a selective segmentectomy and selective lobectomy by targeting only the surgical segments of the liver with the disease. And this is an example here later on with a complete response, reduction of the tumor, dramatic reduction down to 3.6 centimeters. And we can always measure the exact deposition of the energy like radiation oncology. So Y90 is a very interesting treatment because you have to be an IR, you have to be a radiologist, you have to practice a little bit of radiation oncology, and you also have to think like a surgeon when you apply those treatments in the liver. So as I have said, by maximizing and intensifying those Y90 treatments, you can achieve what we call Y90 lobectomies and segmentectomies. And the current state of affairs is what we call the AMARA concept. So this is in contradistinction to the ALARA. ALARA is about radiation protection. The AMARA is about maximizing the effect of radiation in the tumors of the liver. So we need high dose, we need tumor coverage, and we need margin treatments exactly and in line with what we have been explaining previously about microwave ablation. We have also a study, we started this beginning 2024. We got a study studying the AMARA concept in large unresectable tumors of variable histologic origin. Most of them are colorectal liver metastases. And I'm going to share with you a brief interim finding here. We did this checkpoint last week for the sake of presenting some abstracts during 2026. And you can see here 55 cases, median tumor diameter 8.4 centimeters, so really large tumors, and out to 11 months time, complete response exactly like surgery in 3/4 of the cases. So we can achieve surgical-like resection-like results when we do high intensified Y90 treatments targeting the tumor itself, very much in line with a surgical lobectomy or segmentectomy. Interestingly, when we did also the logistic regression, the radiation dose was the only predictor of complete response. It's not about histology, it's not about anatomy, it's not about the other patient variables, it is only about maximizing the tumor dose, the tumor absorbed dose, with a target of at least 250 gray on the rock analysis at the bottom. So to summarize, overall for locoregional treatments in the CRC landscape, there is a high incidence of disease, no doubt. Ablation, no doubt again from the latest randomized data, safer and equally effective with surgical resection. And I think we're going to be seeing a lot more microwave ablation in the future, which is probably the new gold standard. And intensified Y90 treatments by the AMARA concept, I think we're going to be building a lot more evidence over the next couple of years. Thank you very much.